Yeah, thank you, and thanks everybody for having the opportunity to come here today. I'm going to do a little bit of my research, but mostly it'll be overview of other stuff and a compilation of a lot of what's already been said in the room, so I'll try not to be too repetitive. Exercise definitions we already know, so I'm not going to go through that or belabor it in the point, but I do want to point out that there's different types of people doing all sorts of different types of exercises, including the one in the back right corner, who might be a young Kim, who had really worked hard, perhaps not competitively, but possibly competitively, to have external motivations to push themselves, to use that static component as much as they can to bake the largest fish that they could at a different age and time. But remember, look at all of these people here of different ages. So different ages, different components, different motivations to their exercise, which is going to be important for all of us in the continuum of life as we move forward. So quick things, dissection is really rare in athletics. It's so rare that it's skipping forward on this slide multiple times. And most of those patients are ones that did not know that they had aortopathies beforehand. And a number of these patients in here actually included coronary dissections as part of aortic dissection. So it is really, really rare. So it doesn't happen very often. However, there is an impact. Obviously, the vasculature, we've kind of been talking about that all afternoon in athletics, and specifically the weightlifters. This was a great study by McDougall in 1985. They put a brachial artery catheter in and had them do exercise, and the double leg press really brought up their systolic and diastolic blood pressure, and we've obviously learned from the engineers in the room that that is a significant increase in wall stress. And I should note that the guy who won the 73 kilogram weightlifting in Paris actually lifted 354 kilograms for the gold medal. So there's a significant change in this particular population. Diameter in aortic in athletes and aortas, the aorta tends to be larger in these weightlifters, tends to be not quite as large in the endurance athletes, and time also matters. If you do it for a longer period of time, not only do all of our aortas grow over time, but the athletes' aortas also grow. They tend to have a larger diameter. So duration over your lifetime will matter in some sense. And we'll get to that. There is some measurements of aortic stiffness and distensibility in athletes, done some in echocardiography, and I'm sure that there's some other modalities trying to actually look at this. Granted, most of these patients are at rest where these are being done, and sort of the same kind of thoughts and concepts where the strength training tend to have increased stiffness, the endurance tend to have increased distensibility. However, what does that mean in the grand scope of things, and how does that change over the course of the cycle of whatever athletic pursuits they're doing? Because as we've just discussed, many of them are variable, right? So aortopathies and exercise, I just have to do a shout out to these two studies done in 2017, which really changed, at least in the world of aortopathies, moving forward of maybe it's really okay to exercise. These two mice, well, I'm not the researchers, but the mice themselves started to exercise, and at 9 months, the ones with Marfan's, the ones that exercised, basically had smaller aortas than the ones that didn't exercise. That's down here, and their rate of change was also lower, leading credence that maybe it might be okay to do some moderate amount of exercise if you happen to be a mouse. There's another mouse model, also in 2017 by Christina Gibson, which had some great histological data demonstrating that aerobic exercise blocked the elastic fiber fragmentation. So at the cellular level, or at least at this histological level, there's a difference, as well as that there's a difference, again, in aortic size between Marfan's controls and then the ones who actually exercised. And that's what we have for mice. Okay. So that brought Sadat, who isn't here today, to really try to push this forward, at least in children. Can we have kids go out and just exercise, do 10,000 steps a day, which I don't know how many of you are wearing your altimeters. We're not doing well today. Can you do it, and can you do it safely? So this is just sort of an efficacy type of study, right? And what she demonstrated is, again, after about 6 months, she had 22 Marfan patients that exercised 12 controls. Her aortic Z-score rate of change decreased, and the stiffness also decreased, suggesting, again, the whole stiffness model of maybe some of that dynamic exercise is good and maybe some is less good, which obviously we need to learn a lot more about. This is a little bit of research here. We're switching to bicuspid aortic valve, but I kind of wanted to draw attention to, pediatrics patients. They're doing all of this stuff they're technically not supposed to do, even if they're doing it anyway. And those athletes versus non-athletes obviously are going to tend to be more obese. So this is a study just looking at what was the obesity rate in the state of Oregon in our bicuspid aortic valve population. And it's no surprise that those children who were moving, and of course they all took regular sports, those patients that were moving were less obese. And as is seen in other studies, there wasn't any difference in their aortic valve performance, aortic root dilation, or ascending aortic dilation. Doesn't mean they weren't dilated, just means that the ones that participated in sports weren't more dilated than the other ones. But we do now have one paper in lifelong exercise characteristics of valvular function aortic diameters in patients with bicuspid aortic valve. This is a study that just came out relatively recently in the Netherlands. And granted, it was a study where they were following patients, but they also did a questionnaire whether they asked patients whether they'd been active their whole lives. And the nice thing about this study, granted there's a lot of extrapolation, there's a lot of cross-sectional analysis here, but in general, what the hopeful piece of it was is that those patients who had exercise intensity and the sport type really wasn't associated with valve degeneration, aortic regurgitation, or dilation of the aorta over time. And so while, again, this isn't a perfect study, it does give us some sense that longer-term athletics may be okay. We just have to figure out at what rate, at what intensity. And I think that that's important as we move towards the current guidelines, or actually not so much guidelines, but scientific statements and shared decision-making. Who's at risk is what we have to decide as clinicians. Is this person who didn't know they had They didn't know they had Marfan's when they died, and they participated and they were a professional athlete? Is it this 5-year-old who really wants to, by the time they're middle school, be able to do a split and join the junior varsity dance team, and then move to something more dynamic and static at the same time, also competitive? And what does this mean for this child's aorta over that period of time? And at what point are they pushing themselves too hard? And at what point at which is it necessarily good for what they're doing? And what do we need to do as clinicians in order to be able to evaluate that? So the scientific statement, I'm totally in love with. I mean, it's great. But I would say, and this is a blow-up of what Shane had earlier, and I wanted to point out they've done a really nice job of putting different age groups and some guidance to clinicians about when you should start talking about what. They introduced the concept more so of a shared decision-making, which sometimes I think is a little harder to do in pediatrics as the parents ask you, well, what should they do and what should they never do? But I also think that with this mix of sports, with the subspecialization that is going on not only in the US and others, we might need to move some of the discussions a little bit earlier. But we also may need to liberalize what things look like, and how we follow these patients is going to be critically important. So we obviously have knowledge gaps, of course. How do we monitor patients that continue to play in these team sports? Because team sports, unfortunately, are all the ones you're not supposed to be able to do, right? What's the rate of dilation? What's the size? What does stiffness mean? And I'm really looking forward to the engineers so we can do dynamic models of patients. One of the things that we're doing in our lab is we're exercising everybody, because specifically in some of these heritable conditions in Marfan's disease, they also have a lot of skeletal features. So they may have decreased FEV1s just before we've even started it. So is it their heart that's limiting them? It's not. What's a good baseline for them? And what personal goals can they develop if they want to participate in team sports? What are realistic expectations? We need to bring realistic expectations of what we can do with them as opposed to what they can't do. And the last point in here is how do we factor in those with mitral annular disjunction, which is why I'm going to throw in this particular patient, because why not give our personal vignettes here. But this is a recent patient of mine who I was just stressing, and of note she's 14, of note she was just She was just admitted for depression, suicidal ideation about 6 months ago. She got over that. She really wanted to do more. She is, in fact, an athlete. And I'm like, well, I'm stressing everybody, so I'm going to stress you. And I already knew that she had a little bit of a PVC burden, totally asymptomatic, totally fine. She does her stress test. She's great. She actually does about 80% of predicted, which is pretty darn good. But they noticed this, which is ventricular bigeminy of 2 different foci, and a follow-up demonstrated a short run of VT. Now, the good thing is for our exercise people is that it extinguished at 160. And granted, this patient was not on atenolol, so fairness. But this is kind of scary. And so my question then is, does this kid have MAD? Do they not have MAD? I'm still a little bit nervous about how to diagnose it because of the implications of what it means. And I certainly don't know what to do about it with exercise. But if we consider that this patient might have MAD, and this is her MRI, which does not have any fibrosis, FYI, guys, and this is actually the dynamic study that she had on echocardiogram at the time. So this was an adult group, so the adult group did it, so there's high gains here for the pediatric people in the room. But I do think that there is some separation of the mitral valve annulus to the left ventricular free wall here, and it probably does meet that definition of MAD. I think it's a little harder to tell because I know that there's this pseudo-MAD that rolls up on the atrial side, so it's a little harder for me to tell. But this leads into, there's some new guidelines related to mitral annular dysfunction, which leads into a whole scenario of VT and what the risk is and what should we do, and how does that fit in with my little exercise piece down in the corner. And I'm not 100% sure what to do here, and so if anyone in the room does, please let me know. But I wanted to close with trying to figure out how much exercise is too much is really hard. I think that everybody in the room would say, and let's do a handhold. How many people in the room would say that overall moving your body is good? Right. But how many of you also, all athletes in all forms have a time at which they retire? How many of you are retired athletes out there, right? And it's not just because we had an aortic dissection, something else happened. So something else is going to happen. So as we move through life, we need to figure out ways that we modify our own exercise as we're doing in our everyday life that supports people with all of the different diseases that they have. I think that competitive sports in younger generation, except for the violent collision sports and wrestling, which I don't like anyway, is probably okay, especially with active monitoring and shared decision-making. I do want some better parameters, but I think it's probably okay. Now that I've had a few patients go through it, they're overall, well, they're okay now. Rule number 2 is we need to expand and place emphasis on what patients and what we can do for them and turn it more into a positive, because that's really important for quality of life, adolescents growing up, and certainly as you enter into your 20s, because some patients are going to do what they want to do anyway, and so you may as well, as physicians, being partnering with them. And moderate exercise is good. Long-term high-intensity training might have a deleterious inflection point, and I brought that in for the engineer there so that we could maybe figure out what that moment is going to be for our patients. And obviously we need some more data, proved biomarkers and or regular markers for protective effects of exercise, improved evaluation of exercise in the postoperative patient, which Siddharth already talked about, so I don't need to do more. Thank you.